Assalamu alaikum everyone. Today our topic of discussion is complications of myocardial infarction. Let's start with the tachyarrhythmias. These tachyarrhythmias are because of ischemia of conducting system of the heart. At the site of ischemia, there is more influx of sodium and more influx of calcium, which leads to these tachyarrhythmias. It is one of the major cause of death in those patients who die before receiving any medical treatment. So it may be due to the sudden death is due to ventricular fibrillation, or it may be due to ventricular tachycardia, and it is seen in 5 to 10% of the cases. The next complication of myocardial infarction is bradycardia. It is usually seen in the when there is occlusion of right coronary artery, or especially the posterior inferior wall myocardium infarction. It is classified as sinus bradycardia. If it is symptomatic, then IV atropine should be given. If there are no symptoms of bradycardia, then no treatment is required. The next bradycardia type is AV nodal block. If there is first degree AV nodal block and second degree Mobes type 1 AV nodal block, then there is no need of any treatment. But when there is second degree Mobes type 2 and third degree AV nodal block, then temporary pacemaker should be implanted in these patients. The next complication is ventricular free wall rupture. It is the most common mechanical complication. In this case, due to necrosis of the myocardium, there is a rupture of myocardial wall. Due to rupture, there is a filling of blood or shifting of blood from ventricles into the pericardial cavity or pericardial sac. Due to the more filling of blood in the pericardial sac, a condition is called cardiac tamponade. Remember the triad or Beck's triad of cardiac tamponade. It is comprises of low blood pressure, distant heart sound because of the accumulation of blood around the heart, so distant muffled heart sound, and there is raised JVP because of the heart is compressed by the outside blood. So there is raised JVP. So these three features are called Beck's triangle. These are the cardiac tamponade features. The treatment option includes the pericardiocentesis, that is removal of blood from this pericardium, and positive inotropic agents like digitalis or digoxin to improve the contractility of the myocardium, and also hemodynamic stability, and surgical repair of the rupture of myocardium. Rupture of papillary muscle. Papillary muscles basically holds the chorda tendina and ultimately holds the valve of the heart. Due to rupture or necrosis of the papillary muscles, the valves become incompetent. It is a mechanical complication presenting with the acute mitral regurgitation. It presents with the pansystolic murmur because of this mitral regurgitation, and S3 sounds because of overfilling of the left ventricle due to regurgitation. And due to regurgitation, pulmonary edema occurs in these patients. The diagnosis is usually done by ultrasound of the heart. In short, we can say that by the echocardiogram. And the treatment option includes emergency valve replacement of the mitral valve. So this was rupture of papillary muscle. Now come to the next complication, that is interventricular septum rupture. Due to the rupture of interventricular septum, there is a shifting of blood from the left ventricle into the right ventricle. So there is a oxygenated blood mixed into the deoxygenated blood. So there is more pressure in the or more load on the right heart. So the features of right heart failure occurs in these patients due to the left to right shunting in these patients. And there is oxygen step up, that is shifting of oxygenated blood from left ventricle into the right ventricle. And the treatment includes the surgical correction of the septal rupture. The next complication is pericarditis. As we know that when there is a myocardial infarction, there is an inflammation of myocardium as well. Due to this inflammation, that is the presence of neutrophils and macrophages at the site of myocardial injury, so these myocardials, basically the macrophages and neutrophils, also damage the also inflame the pericardium as well. This is called pericarditis, that is the covering outside the myocardium is pericardium, which is also inflamed in cases of MI in some patients. It is usually occurs on second or third day of the myocardial attack, and the patient presents with the pericarditis, that is chest pain and pericardial rub. These are the features of pericarditis. Treatment options includes high dose of the aspirin. Usually the NSAIDs, that is non-steroidal anti-inflammatory drugs, and corticosteroids are contraindicated because these two drugs inhibits or prevents the scar formation, or prevents the or inhibits the healing process. That's why these two drugs are contraindicated in case of pericarditis. Now come to the next complication, which is basically a continuation of pericarditis, that is Dressler syndrome, in which the autoimmune antibodies are formed against the connective tissue of the dead myocardium. So these antibodies try to attach with the myocardium and form against the connective tissue of the dead myocardium, but these antibodies attach to the pericardium and causes pericarditis, as well as attach to the pleura of the lungs. So this is called Dressler syndrome. It presents with the pericarditis because the antibodies are attached with the pericardium, and pleuritis because of attachment of antibodies to the pleura, fever and leukocytosis because of inflammatory processes going on in this mechanism. This is also called post myocardial infarction syndrome. It is basically a pericarditis of autoimmune origin. The treatment option includes the aspirin in high dose, it is a first line, and the alternative therapy is corticosteroids and the non-steroidal anti-inflammatory drugs. The next complication, that is ventricular aneurysm. Aneurysm is basically the out pocketing or bulging of the dead or necrosed myocardium. Basically, the heart failure, ventricular arrhythmias, mural thrombi formation, and systemic embolism, all these are the complications of this ventricular aneurysm. That is, thrombi or mural thrombi are formed within, and it is less motile, so it leads to heart failure as well. So it leads to various complications of myocardial infarction. The other features include paradoxical impulse can be felt on the chest of the patient, and sometimes there is a unstable, unusual bulge from the cardiac silhouette on the chest X-ray, and there is a persistent ST segment elevation in the ECG. It is diagnosis is usually done by the echocardiogram or the ultrasound of the heart, and the treatment option includes the surgical removal of this aneurysm in some patients. Now come to the next complication, that is acute congestive cardiac failure and cardiogenic shock. Come to the next complication, that is acute congestive cardiac failure and cardiogenic shock. It is because of the dead myocardium is less motile, so decreased cardiac output, which leads to decreased perfusion of the coronary arteries as well. Due to decreased perfusion of the coronary arteries, it causes the decreased perfusion of the myocardium, so it causes further exaggerate the process, and due to decreased motility, the patient ends up with the congestive cardiac failure and cardiogenic shock. The management of congestive cardiac failure, as we have discussed in the previous lectures, includes the ACE inhibitors and diuretics and further beta blockers etc. And the cardiogenic shock is managed with the positive inotropic agents and hemodynamic stability and some assisted devices. Now come to the next complication of the myocardial infarction, that is ventricular remodeling. This is a potential complication of the acute transmural myocardial infarction due to thinning and stretching of the infarcted segment. As you can see in this picture, that there is a thinning and spreading and thinning of the infarcted site. There is a increase in the size of infarction, and there is more stretch on or stress on the valve of normal remaining myocardium, which leads to the hypertrophy and dilation of the chambers of the heart, or the dilation of the ventricle, and ends up with the heart failure. So this is ventricular remodeling. It is a chronic process, and it is usually treated with ACE inhibitors, that is captopril and enalapril, and also mineralocorticoid receptor antagonists like spironolactone. The next of the myocardial infarction, that is thromboembolism. When the endothelium or endocardium over the infarcted area is damaged, this leads to the more platelet aggregation and ultimately thrombus formation. And also due to aneurysms of the ventricles are less motile, and these also exaggerate the thrombi formation. These are called mural thrombi, which are formed within the ventricles of the heart, and when it enters into the circulation and reaches the brain, it causes a stroke and also causes the ischemia of the limbs. It can be prevented by early mobility of the patient and also prophylactic anticoagulants. Now, in the last slide, we summarize the complications of myocardial infarction or myocardial necrosis. Due to necrosis, there is a less motility or less contractility, and there is more chances of ventricular thrombi formation, which are called mural thrombi. And these thrombi, when moves into the circulation, and these become emboli and causes a stroke or limbs ischemia. Due to tissue necrosis of the myocardium, there is a reduced contractility. Due to decreased contractility, less cardiac output is generated and causes decreased perfusion of the coronary arteries. Due to decreased perfusion, there is more chances of ischemia, and ultimately there is a vicious cycle is started, and it ends up with the acute cardiac failure or cardiogenic shock. There is a electrical instability because of ischemia of conducting system, and arrhythmias occurs. And this tissue, due to this tissue necrosis, this tissue necrosis may lead to expansion of infarction. Due to expansion of infarction, as we have discussed previously, that there is a more stress on the remaining myocardium. Due to more stress on the remaining myocardium, hypertrophy and dilation of the remaining myocardium occurs. This is called ventricular remodeling, and ultimately ends up with the congestive cardiac failure or cardiogenic shock. And due to tissue necrosis of the papillary muscles, mitral regurgitation occurs. When there is a rupture of interventricular septum, especially the left to right ventricular shunt occurs, due to which the workload on the right ventricle increases, and it ultimately leads to right sided heart failure. And there is a tissue necrosis or the rupture of wall of myocardium, there is a blood pooling within the pericardium, it leads to cardiac tamponade. And there is a pericardial inflammation because of inflammatory cells are present at the site of myocardial infarction. So the inflammatory cells also inflame the pericardium as well, so it leads to pericarditis. So this was whole about the complications of myocardial infarction or complications of acute coronary syndrome. Thank you so much for watching this video.